Hello and welcome to the EduTalk series hosted by Biotone Edu Partner Program, and massage industry experts. With the growing interest and popularity of the EduTalk series, Biotone continues to support virtual learning and building massage community by connecting you with industry experts who share their knowledge and expertise on topics not only for class discussion, but career success. Today's expert is Ruth Werner, an industry writer, educator, and retired massage therapist who began her career in 1984. She's an award-winning NCBTMB-approved provider, teaching continuing education workshops internationally in research, pathology, and related subjects. Additionally, Ruth is author of the textbook, A Massage Therapist Guide to Pathology. Do you need two people to help you lift that?
Yeah, I know.
Now in its 7th edition. And she's an ABMP podcast host of I Have a Client Who. She's also a columnist for Massage and Bodywork magazine and Massage New Zealand. Let's listen and learn as Ruth discusses massage therapists as skin cancer's first detectors. As therapists, you see more of a client's skin than they do, sometimes seeing things that are questionable and need to be referred out. Ruth discusses her recent work on skin cancer education for massage therapists. The most common types, who is most likely to have serious problems, and most importantly, how to discuss the findings in a way that doesn't alarm your client and respects your scope of practice. Thank you again for joining us. Feel free to chat questions during Ruth's presentation, which will be answered at the end. And with that, welcome, Ruth.
Thank you.
I know we have a lot to cover, so I'm going to jump off and I'll see you on the other side. It's all yours.
Okay. Very
Thank
good.
you.
Hello, everybody, and thank you for joining us. And I know many people are planning to catch up with this recording later, so hello to you too. What Donnell just gave you as our goal for today is pretty darn ambitious, considering that I want to try and get through this in about 40 minutes. So I'm going to share my screen, and Donnell, I will just ask you to speak up if it is not what we are expecting. And we are going to do kind of a flyby of skin cancer. And as Donnell mentioned, I recently have done a lot of work on skin cancer education. And within our presentation today will be links to the complete Massage and Bodywork feature article, plus another follow-up article on this topic that is really, really rich and full of beautiful illustrations. And I also, created an online continuing education course for ABMP that is an hour and a half. It is free to ABMP members, and it is cost effective for anyone who's not an ABMP member. So if you like what you see now and you'd like to get more, I will show you, where to find that. So thanks to Biotone, and here we go. Before we dive in, and I'm just going to probably be talking pretty fast so that we can spend some time looking at the pictures, which is why you're here. But we need to do just a really quick review of skin structure. This is an image that is just the very outer layer of the skin. It's the epidermis. And what we can see from this is that there's the stratum lucidum, which tells us that this is a slice of epidermis that comes from the palm of the hand or the sole of the foot. That's where we have the stratum lucidum. But as we look at this, I want us to remember, where are the basal cells? And for whatever reason, they've spelled melanocyte very oddly here. But here is the stratum basale down here at the bottom of the epidermis. The squamous cells are all of these. that are being, they're born down here at the stratum basale, they migrate outward, they fill up with keratin as they go, and of course, by the time they get to the stratum corneum, they are dead, and they are flaking off all the time. Those are our squamous cells. And the last item that I want to make sure you find on this picture, although it's colored in a very subtle way, is the melanocyte. That's our pigment-producing cells, and you can see these little dots that the melanocyte is making. That's the melanin, and that's what gets into our squamous cells to give them some color. And some people have lots and lots of melanin, and some people have a lot less melanin, and that has some repercussions for skin health in general. So when we look at what causes or the contributing factors in all of the types of skin cancer put together, there are a few main things. Basically, what's happening here is that those skin cells, which replicate quickly, which is a great protective device, right? But they replicate quickly, and that means every time they replicate, there is a risk for a minor mutation as those cells reproduce themselves. And if that mutation happens to be an undesirable one, a non-optimal mutation, what may happen is that we may develop skin cancer. So this begins with a mutation in skin cells. And the triggers for these mutations often has to do with repeated injury, which requires that the skin reproduce and fix itself, right? So we have a history of UV radiation, which is sunburns. There's a genetic component. We do see that the risk for skin cancer runs in families, but that's only one factor among many. When we have an area with chronic and repeated skin inflammation or injury, like repeated sunburns or a skin ulceration that comes in the same place every time, or burns that never really heal very well, these chronic repeated injuries are also risk sites for skin cancer. There are toxic exposures that appear to raise the risk for skin cancer. The main one off the top of my head is living in a place where there's arsenic in the water, maybe at low enough levels that it doesn't make you visibly ill, but it does raise the risk for complications, and skin cancer is one of them. And we find that people who are immune suppressed, either because of maybe being HIV positive and moving into AIDS, or immune suppressed because they are needing to take drugs that suppress their immune system for chemotherapy or autoimmune disease or organ rejection drugs, immune suppression raises the risk for skin cancer. There are three main categories of skin cancer, and we're going to look at each of these, starting with BCC, which I hope you remember stands for basal cell carcinoma. And here are a whole bunch of people that are inviting basal cell carcinoma into their lives, as we do, because sunshine feels so good. I live in the Pacific Northwest, and sunshine here is a treasured commodity, but I get nervous when I see families on the beach, even on a cloudy day, and their kids are running around because it's warm and they're not wearing protective clothing. That is a sunburn waiting to happen. So with basal cell carcinoma, what we see is, for the entirety of the population, this is the most common form of skin cancer that is diagnosed. And it comprises about 80% of all skin cancer diagnoses in the United States, which means it's diagnosed about 4 million times a year. Basal cell carcinoma is by far the most common form of skin cancer seen in people who are fair-skinned. It is not necessarily the most common form of cancer found in people of color, and we'll come back to that in a little bit. The basic unifying feature of basal cell carcinoma is that we have slow growing tumors at that basal level, the deepest layer of the epidermis. This usually happens on the head or on the face or somewhere on the head. I've seen it on the scalp and behind the ears. It's usually on the head or face. And another really, really important thing to understand about basal cell carcinoma is that it almost never metastasizes. And we might think that that makes basal cell carcinoma not a big deal and totally safe, and who really cares, because it's not going to spread from a little mark on your face to your liver or your bones or your brain. Okay, it's not going to spread very likely, but what it can do while you're not looking is invade healthy tissues. And we'll say more about that in a few minutes. So basal cell carcinoma, while it does not metastasize, it can cause a lot of damage and grief. Now, I need to give you a little bit of a warning because we are going to look at pictures of people with skin cancer starting now. So if this is something that you're sensitive about, this is a class about skin cancer. So the most common form of basal cell carcinoma is called, there are several types of basal cell carcinoma. Beg your pardon, I went out of order. There are several types of basal cell carcinoma. In order to stay within our time limits today, I have chosen to share with you two types: nodular basal cell carcinoma and morphiiform basal cell carcinoma. Nodular is what we see here. It is a very unique and consistent presentation of a sort of pearly, shiny, trying to get my cursor right here, a pearly, shiny edge around what looks like an ulceration. One of the factors in basal cell carcinoma is that you'll see this ulceration, but it doesn't hurt. So it can look a little icky. And sometimes that'll crust over and the crust will fall off, but it doesn't always heal. And that's an important factor to remember. Here are some more pictures of this nodular type. Sometimes these are called rodent ulcers. And here again, on top, we see this really characteristic raised, pearly edge on fair-skinned people. It often looks a little pink with this ulceration in the middle. And if you look very closely, you may see, you can kind of get a sense of them here, tiny little spider veins, the telangiectasias, that are feeding this growing tumor. This is a tumor. The picture on the bottom is a really important one because this is a nodular basal cell carcinoma behind the ear of a Black man. And it doesn't look like the other basal cell carcinomas we've seen. And one of the big issues about skin cancer, and I will probably be beating this drum a lot today, is that people of color are under-addressed. The assumption is that people of color are at less risk for skin cancer, and so they don't have to worry about it because they don't get skin cancer. That's not true. And when they do get skin cancer, it looks really different from what the textbook looked like, because the textbooks take pictures of skin cancer on fair-skinned people. And so one of the things I did with this class and with, in particular, with the article that I wrote for Massage and Bodywork is I really invested a lot of time and effort into finding pictures of skin cancer on people who are not white, because it often has a really different kind of presentation. Okay, so are we all done feeling behind our ears now in case there was something like a freckle or a little mole that we didn't know was there and we should maybe get looked at? So the other, the last point to make on this slide is that basal cell carcinomas may itch, they may bleed a little bit when that scabs over and falls off, but they are typically not painful. It's a dangerous thing about cancer, it doesn't hurt. Morphiiform basal cell carcinoma, if you look at that word morphia, that refers to one of the versions of lupus that looks like scarring. So basal cell carcinoma that looks sort of like lupus is what this name means. It is of the types of basal cell carcinoma. Remember, there are several others that we're not talking about today. Morphiiform basal cell carcinoma is the most serious. And the reason it's the most serious is that its presentation is a very minor little mark on the skin, but with deep and invasive tentacles, if you like, going deeper into the tissues. And this is an example of a theoretically, not serious kind of skin cancer because it doesn't metastasize. But what it can do is, in the top picture here, it began as this little white scar-like lesion, but now it has invaded the cartilage of this person's nose, and he is on his way in for a pretty invasive plastic surgery. With the picture on the bottom here, I don't know what part of the body this is. By the absence of hair, I'm going to guess this is probably a woman, although this could also be someone's scalp. And what I want you to get from this picture is the sort of drawn in, contracted look to this. And if you palpate it, it will feel like scarring. I once had an acquaintance who had a basal cell carcinoma on her mouth. And Donnell, this is different than the story we were talking about before we got started today. She had a little lesion on her mouth. She ignored it. It didn't go away, and it didn't go away, but it didn't appear to be getting bigger on the surface. But by the time she went in and had it looked at, it had invaded into her sinuses, and she had to have a pretty substantial facial reconstruction in order to get the whole tumor out. And if they don't get the whole thing, it may well grow back. So that's morpheaform basal cell carcinoma. The classic sign of any kind of skin cancer that is not melanoma is this: a sore that doesn't heal. And many, many years ago, I was working on a project on skin cancer. This is probably 20 years ago or more. I was working on a project on skin cancer, and I happened to be living in near Salt Lake City at that time, and there's a big cancer care center, the Huntsman Center, in that area. And I called them on the off chance that I might get to talk to somebody to do some fact checking. And I asked about this classic sign, a sore that doesn't heal. And the person I spoke to was very, supportive and in alignment. He said, yep, that's absolutely true. But I would add to that a sore that comes and goes in the same place. So a person will have a mark on their skin. They'll get an appointment with a dermatologist 3 days before their appointment that they waited 3 months for. It goes away. And then right after their appointment, it comes back. Right? So a sore that comes and goes in the same place is another sign or symptom, if you like, of basal cell carcinoma. And the word sore is vague on purpose, because this can look like a little ulceration. It can look like a bug bite. It can look like a little spot of flaky skin. It can look like lots of different things. And so if there's a lesion on the skin and it doesn't look like much, but it's not going away, that is something that really needs to be pursued with certainly at least a GP, but very likely a referral to a good dermatologist. What do we do for basal cell carcinoma? The mainstay of treatment is to cut it off. Surgically remove it. If they get a clean border all the way around it, there's very low threat of metastasis. It is the simplest and fastest way to a cure, if you like, because it's done and it's not going to come back for this form of skin cancer. And that's all I'm going to say about basal cell. And now we're going to take a breath. This is my dog, Gaia. Gaia is no longer with me. We have rehomed her to a place where she has a big yard to run in because she turned out to be problematic as a beach dog, but she sure loved her seaweed. And we'll take a breath. And now we'll talk about cutaneous squamous cell carcinoma. And if you really decide that your life will not be complete until you can say, I am a cutaneous squamous cell carcinoma survivor, this is a great way to meet that goal. But I just really recommend that you don't do that. And I'll, remind us that we are role models for our clients. And so we need to also role model good skincare. So squamous cell carcinoma is a cancer that develops in the keratinocytes. These are those squamous cells that are filling up with keratin as they migrate toward the surface. Oh, let me do it on this screen. So here are our squamous cells that are filling with keratin. These are the ones that are vulnerable to squamous cell carcinoma. And so this develops at the second to deepest layer of the epidermis. We usually see squamous cell carcinoma of the skin develop in areas exposed to sunlight. So arms, legs, trunk, belly, if you sunbathe with a bathing suit that exposes that part. And again, face, head, I've seen it on hands. My husband has had a few on his legs, areas like that. But unlike other forms of skin cancer, squamous cell carcinoma can also develop inside the mouth. And I'm not going to share pictures of that with us today because I had to edit. But I will say that when a person develops cutaneous squamous cell carcinoma inside the mouth, it's usually related to tobacco use, cigarette smoke, pipe smoking, cigar smoking, and chewing tobacco are all ways that people will develop lesions inside the mouth, and that will then invade into the bone and possibly deeper. This is a type of skin cancer we see as a real risk for long-term or repeated skin injuries. So people who have boils that recur in the same place, or ulcerations, or burns that, don't heal well or keep opening. This is a risk for squamous cell carcinoma. It is rare, but not at all unheard of, for squamous cell carcinoma to metastasize. And I was mentioning to Donnell that we have a mutual friend who had a squamous cell carcinoma on her mouth, got it checked. They removed it, but it did not come back with clean margins. And what they discovered is that it was spreading by way of perineural invasion, around neural, the nerves. So these cancer cells were using the tracts of her branch of the trigeminal nerve to travel deeper into her body and could possibly have metastasized to the brain. And she had to go through a very, very aggressive series of treatments that were really hard. So we tend sometimes to think of squamous cell carcinoma, because it's not melanoma, that it's not really that big a deal. And lots of times it's not really that big a deal. However, it can be, because it does have the potential to metastasize through the bloodstream, through the lymphatic stream, or through perineural invasion. I'll add here that this acronym CSCC is here to delineate that it is cutaneous squamous cell carcinoma. And the reason that this will appear sometimes in the medical literature is to distinguish this from squamous cell carcinoma that happens in other organs. For instance, there can be squamous cell carcinoma of the cervix or of the uterus or of some other areas. So we use the small c to delineate that this is happening in the cutaneum, or the skin. I don't know if cutaneum is a word. So here are some interesting statistics. Among the majority of the population in the United States, this is the second most common type of skin cancer. Of course, the first one is basal cell carcinoma. However, among African Americans and people at the darker end of the spectrum of skin tones, squamous cell carcinoma is diagnosed more often than basal cell carcinoma, and it is diagnosed at a later stage in people of color than it is in people with fair skin. And, the reasons for that are many. One is we don't have good representation of these lesions in skin of color for doctors to be trained with. Two is an issue of access to healthcare and trust between patients and healthcare providers. And three is people with skin of color often get the message that they just don't need to worry about skin cancer. And so, between those three things, what we see is that when or if skin cancer develops, it's going to tend to be found at a later stage and consequently be a lot more complex and difficult to treat. I'm sharing this statistic with you. The Skin Cancer Foundation is an organization. I don't know a lot about them, but they've produced a lot of useful materials, at least things that I found useful. And their finding is that in the United States, 15,000 people die every year of squamous cell carcinoma. That makes this more deadly than melanoma. And I don't know if you remember this from massage school, but what got drilled into me over and over again, and that what I then consequently drilled into my students over and over again, is that the leading cause of death by skin cancer is melanoma. But if this statistic is accurate, and I will say that this statistic does not match the American Cancer Society statistic, but if this statistic is accurate, this means that squamous cell carcinoma is twice as deadly, kills twice the number of people in the United States every year as melanoma does. So we'll talk a little more about that later. So there are, again, several types of cutaneous squamous cell carcinoma. We're going to look at two. We will look at the typical sort of textbook case of cutaneous squamous cell carcinoma, and then we will look at a subtype in two forms called actinic keratosis or actinic cheilitis. And as I've said, there are several others. This word actinic refers to the sun. And so we expect to see actinic keratosis and actinic cheilitis in places that are exposed to the sun. And indeed, most of the time we see this on the face or the head. But first, let's talk about cutaneous squamous cell carcinoma. So here's your little content warning. We're going to look at some tumors. In general, one of the things that we see with cutaneous squamous cell carcinoma is that it tends to look a little more alarming. The lesions tend to be bigger and redder and look more inflamed than than basal cell carcinoma lesions look. They are still not very painful. They tend not to be painful, although they may itch and they may ulcerate. When they are biopsied, they may be described by histologic grade, and we don't have to go into that. We usually see these on sun-exposed areas, and they use these routes of metastasis. Like I mentioned a few minutes ago, they can move to other places in the body, the liver, the brain, the bones, typically by way of the blood or lymphatic flow, or the brain by way of perineural invasion. The picture on the upper right, this comes from a wonderful website. And Donnell told me we may have some educators with us today. So I want to point you to dermnetnz.org. This is an organization out of New Zealand that has collected a really extraordinary library of images. And in particular, they're really good at finding images of skin cancer on people who are not always fair-skinned. And this is a picture of a cutaneous squamous cell carcinoma of a type that is most common in people with skin of color. And as you can see, by the time this person had their picture taken, it is already pretty advanced. And that's sadly not unusual for people of color who get their pictures taken because they have skin cancer. It's usually pretty far advanced because there's a delay between when something begins to happen on the skin and when it is noticed. All right, let's talk about actinic keratosis. Let's talk about actinic keratosis and actinic cheilitis. These are sometimes called solar keratosis because remember, actinic has to do with the sun. It used to be that these lesions were considered pre-cancerous. They were like a thing that might someday become cutaneous squamous cell carcinoma. But what we found was if they're not removed, it's not a question of if they become SCC. It's really a question of when. And so now many dermatologists just consider this an early stage of squamous cell carcinoma. And these are, you'll have to look a little closely, but these are these pinkish, brownish, scaly lesions on this fellow's forehead. This is a lot of what it looks like on my sweetie, although he doesn't have any, he's all forehead now, so we watch for this very carefully. Left alone and neglected, these things can develop quite, they can get really ingrained and hard and scaly, like on this fellow's ear. And what we're looking at, this picture of actinic cheilitis, which is the same thing, but it's happening on the lips, are these little bumps and ridges and flaky spots on this person's lips. So brown or red or whitish scaly lesions. And that's what actinic cheilitis is. So the signs and symptoms for squamous cell carcinoma are the same as those for melanoma, which is a sore that doesn't heal or a sore that comes and goes in the same place. As we have said, it often occurs where there has been previous injury, previous sunburns, previous ulcerations, previous boils, whatever, things that happen where the skin gets damaged. Also, there are versions of this that can happen inside the mouth. And where basal cell carcinoma lesions tend to have pretty well-defined borders, at least the ones that are not the morpheaform. And these tend to be a little more vague around their edges. Cutaneous squamous cell carcinoma might be frozen off. It might be removed with liquid nitrogen. It might be treated with topical chemotherapy. And if you have this, or someone who lives with this, there's a skin treatment that is sometimes recommended for the face that is almost like a chemical peel. It's really harsh and very, very painful, and you cannot have any sun for 2 weeks, and it's very, very intense. But for some people, it's a good option because you can do it once, and then as long as you're taking good care of your skin, the risk of having recurrences, gets a little lower. If they get deep, they may need to be surgically excised, and, they may need to be treated with radiation. So the meds we might see used for squamous cell carcinoma would include things like chemotherapeutic agents, oral or injected, and photodynamic therapy, which is a protocol that uses certain kind of medicine along with a certain level of UV radiation that kills cancer cells. And now we'll take another breath and look at Gaia in the sunset and talk about melanoma. So, the three main types of skin cancer that we are talking about today are basal cell carcinoma and squamous cell carcinoma. Both of those involve sores that don't heal, little marks or lesions that come and go in the same place, but the risk of metastasis is pretty low. That is not true with melanoma. So this is a cancer that begins in the cells that produce melanin. Those are our melanocytes. And in this picture, the melanocyte looks sort of like a starfish. Okay. The thing about melanoma is if these cells begin to metastasize or begin to replicate, they metastasize pretty easily to the liver, to the bones, to the central nervous system. Usually we think of melanoma as being a type of skin cancer. There are versions of it that affect the eye, and there are versions of it that have been found in the GI tract and in the genitourinary tract. Pretty rare, not related to exposure to sun. Melanoma has a good prognosis if it is found very early. And the basic sort of through line for that is if the lesion is really shallow, if it's less than 0.8 of a millimeter deep, then the prognosis for full recovery is pretty good. If it is found with a deeper lesion, more than 4 millimeters, that means that it has probably metastasized, and we're looking at a much more involved and aggressive and complicated treatment option. It is the least common, and we used to say most dangerous type of skin cancer, but now we know that depends on who you ask, because the American Cancer Society and the Skin Cancer Foundation do not agree. We see they do agree on this number that somewhere between 1 and 200,000 people every year are diagnosed with melanoma, and about 7,600 people die every year from melanoma. And interestingly, that happens in men about twice as often for women. And then here's a statistic that sort of makes my blood boil, which is that the 5-year survival rate for melanoma among fair-skinned patients is 93%, which is pretty good. And the 5-year survival rate for melanoma found in Black patients is 71%, and that is not good enough. And, why does that happen? Delayed diagnosis, access to healthcare, training and education about good skin protection and skin checks, all of those things, and education of medical professionals, all of those things sort of conspire together to make people of color more at risk for having the dangerous forms of skin cancer. So there are several types of melanoma. We're going to look at 3. Starting with superficial spreading melanoma. This is the most common form. And as you can get from the name, it is superficial. So it's the type that's going to have a good prognosis if it's caught early because it grows very shallowly to start with. This picture on the bottom is an upper shoulder of a Black person. And the lesion is just this little darkening in the middle, which would be really easy to miss. This picture was a big score to find this. And I want you to think about your perception. You get to see the backs of people's shoulders or the tops of their shoulders or places in their body that they and their, if they happen to have a partner, may not particularly notice. This is a very subtle presentation. That's another reason that skin cancer might not be found early in people with darker toned skin, because it's harder to see. But that means people who are looking at skin need to be really careful, need to be really aware about it. Lentigo melanoma is a type of melanoma that looks like age spots. We usually see it on mature people. Many people who are older have very flat they look like big freckles on the surface of their skin, especially in places that have been exposed to the sun a lot. But sometimes those completely benign age spots are not benign. They are a form of skin cancer. And it's very interesting that a characteristic of lentigo melanoma is that it has a notch. Do you see how this one sort of looks like a little Pac-Man? And this one here has that sort of scalloped edge. And that's a sign of lentigo melanoma. And acral lentiginous melanoma is the type that is most common among people of color, although white people can get it too. It is not age specific. So most of the time we look for skin cancer among people who are mature, but acral lentiginous melanoma is as likely to happen in young adults as it is in older adults. And unlike other forms of melanoma where we see it on the face or the head or the trunk, we often see this one in places like the surface of the foot or between the toes or between the fingers or under the fingernails. And so we see a couple of things happening here. In this picture on the top, he had a little freckle under his toe, but it turned out not to be a freckle. It turned out to be skin cancer. So if you want to quickly slip off your socks and shoes and take a peek, I encourage you to do that. In the years I've been teaching this to probably several thousand people, I've had a couple of people reach out to me to tell me that they found something unexpected and their doctor was really glad that they had. So this usually begins on an extremity. With this lower picture, we can see that this has clearly been here for quite a while. It's calloused around the edge. It looks like it's protruding deep into his skin. And so he is probably in for a difficult treatment protocol. So melanoma may begin as an existing mole that then later in life changes, but truthfully, most of the time it begins as a whole new growth. It can look like a mole, but it becomes itchy, it bleeds, it grows hair, it changes color, it changes over time, and moles are typically pretty stable. I don't want to linger too much on the ABCDE. I really encourage you to go back to whatever pathology textbook you went to massage school with to remind yourselves what ABCDE stands for. But normal growths tend to be symmetrical. Melanoma tends to be sort of blotchy. Normal growths tend to have really clear, well-defined borders. Melanoma tends to have kind of fuzzy borders. Normal growths tend to have one color. Melanoma tends to be multicolored. Normal growths tend to be small. Melanomas might be bigger. Sometimes they're small, but they're nodular and they might penetrate deep into the tissue. And normal moles don't change over time, but melanomas, of course, do. They change in their size and their shape and their color. Treatment for melanoma depends on the size and its stage and its location. We can be talking about topical chemotherapy or cryotherapy or surgical excision and more. I won't dwell on the medications. Let's take a break, or a breath rather. And then I want to talk a little bit about our job, our role in the context of skin cancer. So when we think about what's the worst thing that can happen if a massage therapist is careless and not well educated and not paying attention, and they have a client who has skin cancer. Well, we could ignore an important sign that needs to be investigated. That's a risk. Or we could say, oh, great looking basal cell carcinoma you got there, and terrify someone because it sounds like, oh, you're going to die of skin cancer. So we can create alarm with the poor use of language. We could conceivably, unlike most other kinds of cancers, we could conceivably actually rub on a tumor. And we agree not to rub on skin cancer tumors. We can disrupt tissue that's been recently treated, like with topical chemotherapy or with a Mohs procedure where it's cut out and then sewn up again. Or we could do things that exacerbate the side effects of treatment, like nausea or fatigue. However, there are tons of benefits we can also offer if we are careful. We can bring important things to our clients' attention, but we have to be really careful about our scope of practice and the way we do that. So we want to do that without causing unnecessary alarm, and I'll say more about that in a moment. If someone is in treatment for skin cancer, then we know that skilled massage, and I would say in the context of treatment for cancer that has metastasized, this is time to get advanced education in oncology massage therapy. But skilled massage can improve sleep and reduce pain and be supportive during cancer treatment. Please don't dabble with this. Please, if you have a client who's dealing with cancer of any type, and you want to work with them safely and effectively, get some advanced education in oncology massage therapy. And people who have finished their skin cancer treatment, I had a little thing snipped off my tummy and had a little butterfly bandage that came back benign. I completed my treatment for skin cancer and there were no particular risks for massage, and it was all benefits for me. So actually, let's come back to this and talk about language, because there are many ways to do this well, and there are some ways to do this really, really poorly. A way to do this poorly is to say, wow, that looks like a basal cell carcinoma. You better get that checked out. Or, that's a funny looking mole. That didn't look the same the last time I saw you. While a person is on your table and they're in that lovely trance state, that might not be the great time to have that conversation. So we need to be careful about what we say, and we need to offer the right kinds of support. So one thing we could offer to do, and you'll have to gauge when is the right time to make this offer, is if you notice something on your client's skin that you haven't noticed before, or that gives you some cause for concern, you can offer to take a picture of it for them with their camera, not yours. We don't put our clients' pictures on our phones, right? But in that way, your client can see it, take it to a doctor, check in with their loved one, see, compare it to previous. So we can offer to be supportive. We may need to, if it's something that's really alarming, it may be necessary to say something like, for your safety, I need for you to get this looked at before we work together again, because I want to be really sure that everything is safe here and I'm not going to accidentally cause any damage. But the main thing is to keep our clients' wellness and well-being at the center of our communication. And I go on about this in some length in the magazine article. So I want to remind us that we are role models for good skincare, and we are public health educators in the sense of helping our clients with any kind of skin tone to increase their awareness of skin cancer risk. And, you know, think about what's the right kind of sun protection for you. And at this point, I will open the floor to questions. So Donnell, I'm going to ask you to come on back on. We have, oh, look, I did it in 46 minutes. That was not too bad.
Well, congratulations. Why don't we take your screen share off?
Okay.
And
Very good. Let me just finish,
okay,
these
finish
little
that.
things up. So this is Donnell will have this link for you, and it's in the little handout that I prepared. So here's a link to the article on skin cancer, and here are some other things. Here's a link to the 90-minute course. Here's my website. Here's my Facebook page. Here's my podcast. So join me in any of those spaces. And now I will stop share, and we'll kind of open the floor to see if you have any questions. That was sort of a fire hose of information, and
It was.
I apologize, but you know, this stuff is really important. And if the main thing I did is make you curious and you know, feel like you want to dive into that with a little more depth, then that's a win. And I've given you some resources to do that.
Well, excellent information, Ruth, and thank you so much for that. And I will use myself as example, being one who is at risk. I am the fair-skinned,
fair-skinned, mature
sunbather.
lady living in the sunshine.
Right.
Yeah.
I mean, we were dragged to the beach when we were little, maybe a dab of Noxzema or something on our nose.
Oh my gosh. Oh, do you remember, because we are of an age, copper tone for the Saint-Tropez tan. Yeah.
Yes. Yes.
Yep.
And the reflectors and everything else.
Oh yeah.
So, you know, two things that I'd like to share with people is that even when I have gone to the dermatologist and I have liquid nitrogen done, I've had something called blue light, which takes care of the whole face.
That's that photosensitivity that I was talking about. Right.
You know, sometimes as I mentioned earlier, that I have to keep on top of my dermatologist. And if I notice something and I think they've breezed by it, definitely I have to come back and bring their attention to it. And as I mentioned, I had a 6-month bringing something to one doctor in the practice attention to 6 months later, bringing it to another doctor. Neither of them necessarily thought it was much to be alarmed about, but we took a biopsy and it was the squamous cells.
Which has a risk for metastasis.
Right. Now, on the other hand, I do get massage. And I feel like if I'm noticing it, I'm not always seeing the same therapist, but if I'm noticing it, you're laying on the table and you're wondering, is anybody else going to notice it?
Mm-hmm.
And I would like to say to the therapists that are listening, it would be great, even if you don't think it's anything, even if you haven't seen this client before, you might just want to somehow find the appropriate wording. You know, has this been, you know, I'm noticing.
Well, yeah, the appropriate wording is, I notice, fill in the blank, try to find some non-alarmist language. I notice a spot here. It is probably nothing, but it might be something. Have you noticed this before?
Right.
Right. I get a condition that I'm not going to show you because it would involve taking my top off, but it's called seborrheic keratosis, and it's like brown, warty, sort of pasted on, like raised freckles, and it's age related, and my mother had them all over and whatever. But I had a new one on my back, and several people said, you have something on your back, you got to get that looked at, which I did, and my doctor was like, yeah, what else you got? So which is fine, and it has not changed.
And that's something you keep
says, so much valuable information. What do you think about mole mapping? if I'm going to take a guess, I'm going to use context clues to figure out what mole mapping is, because as a specific term, I'm not familiar with it. But if it means, taking a pretty solid inventory of where your skin marks are, I think it's a great idea, especially if there's skin cancer in your family. If you are someone who has lots and lots of moles and lots of freckles, what you want to look for, again, according to the people at the Huntsman Center, they used what was called the ugly duckling principle, was look for a growth that doesn't look like the others, because that's the one that's going to behave differently from the others. And if you do regular mole mapping, or if you do a regular skin check, I mean, it's a good practice. Do it on your birthday. Make it part of your self-care every year. And that way you have a baseline and you have some points of comparison. So I'm in favor.
Oh, great. Well, I haven't seen any other comments or questions come in, Ruth. And I would like to mention to everyone, tomorrow you will receive a follow-up email. It will have this recording link. It will have Ruth's contact information, and it will include a handout that covers a lot of the material from Ruth's PowerPoint this evening. If you have any questions, and again, her contact information will be in the email, please feel free to reach out to Ruth. This is an important topic, and one we need, not only myself as a non-professional, but as professionals that see more of me than anyone else, definitely speak with your client and become familiar. I'd like to mention upcoming EduTalks, and then Ruth, is there anything you'd like to say in closing before I get into the upcoming EduTalks?
Yeah, no, I just want to say thanks everybody so much for coming. I hope this makes you want to find out more. And one of the great things about that Massage and Bodywork article is they went to a great deal of trouble. They and I together went to a huge amount of trouble to find many, many more images of skin cancer than I just showed you on skin of many different tones. And you can have a hard copy of that to have with you. I mean, you can print it out or whatever. I just think it's such a valuable resource. And I would love to see massage therapists become a little bit more activist in terms of raising skin cancer awareness, not just for our fair-skinned clients, but for our clients also who have skin at the darker ends of the scale. Yes, and I will repeat what John said. Thank you so much to Biotone. That's my closing statement, Donnell. Thanks, Biotone, for this opportunity to be helpful. It's always great to spend some time with you and to reach out to people all over the world who have checked in to get this information.
Yes, thank you. And to mention the upcoming EduTalks, because we have a great summer lineup, on June 20th, we will have Eric Brown, and he'll present on the fainting phenomena, why people faint during chair massage.
I have seen that again and again. I want to, I will probably attend that one because Eric knows what he's talking about.
I never heard of that before, so I'm interested.
I've seen it, when you do like massage on site, like at a fair or a craft show or something like that, and people will get up and they will fall over.
Yep. Oh my goodness. So that will be a good one. July 11th, we have Sally Spurgeon, breast massage for breast health and post mastectomy. And
mastectomy, probably.
Excuse me?
Mastectomy, yeah.
Oh, okay. I guess I wasn't listening to myself. I'm on to the next one already, but thank you for the correction. And July 25th, we have Marianne Cisco, craniosacral therapy for post-concussion relief. And
really important topic. Huge topic. Post-concussion syndrome is a really tough situation.
All right, so great lineup. Something new for everyone is that we have a new series of EduTalks, and that is EduTalk Diabetes Series, and it launched May 16th. We have a second talk coming up June 13th, next week, next Tuesday, diabetes, and it's diagnosis to freedom. And she'll give 5 tips during that presentation. And that's with Irina Stranina. These EduTalks as well, the diabetes series, are recorded. They are posted to the easy.com website under EduTalk Archive Library there. And you can also RSVP directly to the upcoming EduTalks on the Easy website. I will include that link in tomorrow's follow-up email as well. And I haven't seen any other comments or chats come in. Ruth, this is fabulous. Thank you. You're right. It would be great to have therapists champion this with their clients and even finish a massage off with a little sun lotion. So there we go.
Put on a little sun cream. Yeah, it's a little sticky.
I know.
Thank you. Thank you,
know.
Donnell. Thank you, everybody, for being here. It was a pleasure to spend some time with you.
Thank you, everyone. Be safe and watch your in-basket or spam folder for follow-up email and invitations to the next shows.
And
Take
put
care.
on some sunscreen.
Yes.
Okay.
Thank you. Thank
Bye-bye.
you very much. Bye-bye.